Welcome, everybody. I'm Lori Meschke. I'm faculty in the Department of Public Health at the University of Tennessee, and it is my great pleasure to be serving as your host for today's East Tennessee Regional Health Consortium meeting for our winter edition. So today's focus is going to be on medication for opioid use disorder, and just to go through a little bit of housekeeping. This is the East Tennessee Rural Health Consortium. If you are not a member of the consortium and would like to be, just simply email me and I will add you to the listserv, and you'll get all of the announcements and access to our newsletter, etc. If you'd like to learn a little bit more about the consortium and what we do, you can also check out our website, which is tnopioid.utk.edu, and there you'll find a wealth of not only the recorded presentations like the one that you will be seeing today, but you will also see other assorted trainings, fact sheets, and also events that our community partners and the university are putting on related to opioid use disorder and greater health in rural East Tennessee. I would kindly ask that if you are not speaking, that you would keep your video and your mic off. This will be really helpful for those persons who have less access to broadband and will help keep things moving for them instead of having their screen free. So that's excellent. We will have Q&A following each one of our presenters' presentations today. And with that, I would ask that you would put your comments or your questions in the chat, or feel free to show your video or unmute yourself and join the conversation following each of the presentations. So it's now my pleasure to introduce our three guests. I'm going to introduce them all at the very beginning so we can flow into our presentations and get on to our enjoyment of the afternoon together here. So our first presenter is Dr. Wes Gemin. He is the Chief Pharmacist and State Opioid Treatment Authority for the Tennessee Department of Mental Health and Substance Abuse Services in the Division of Clinical Leadership. Dr. Gemin graduated from the University of Tennessee College of Pharmacy with a Doctor of Pharmacy degree in 2011 and completed a postgraduate residency in Managed Care and Psychiatry with the Tennessee Department of Mental Health and Substance Abuse Services. He is currently board certified in psychiatric pharmacy by the Board of Pharmaceutical Specialties and serves on several state and federal boards and committees dedicated to serving those with mental illness and substance use disorders. We welcome Dr. Gemin. Our next presenter is Dr. Jennifer Torville. She holds a Doctor of Nursing Practice degree from Vanderbilt University. In her former role, she was faculty at UT Knoxville College of Nursing, where she taught newborn and pediatric courses and mentored student research related to neonatal opioid withdrawal syndrome. Jennifer currently leads a team at the UT Institute for Public Service, SMART initiative, that works with local governments to develop, plan, and initiate programs to abate substance use. She also still practices part-time as a pediatric nurse practitioner and serves on various community boards and task forces. Welcome, Dr. Torville. And our final presenter of the day will be Dr. Tyler Melton, who is an assistant professor in the Department of Clinical Pharmacy and Translational Science and Rural Health Program Coordinator at the University of Tennessee Health Science Center, College of Pharmacy. He has over 12 years of pharmacy practice experience, including inpatient and outpatient pharmacy in rural environments. Tyler joined the University of Tennessee Health Science Center in September of 2020 after completing a postdoctoral research fellowship in community pharmacy practice and prescription drug abuse, and earning his Master's of Public Health from East Tennessee State University. His areas of research expertise include community pharmacy practice, rural health, health disparities, substance use disorder, and prescription drug misuse. Welcome, Tyler. We will be having an evaluation following this session, and I will be posting this later also. But if you want to go ahead and bring up the evaluation and fill it out as our presenters are done speaking, you're very welcome to do that too. So without further ado, I will turn the floor over to Dr. Gemin. Thank you.
All right. Thank you, Dr. Meshke. Thank you to the East Tennessee Rural Health Consortium for inviting me to speak on a topic I'm very passionate about, along with such esteemed presenters. For the first part of our consortium today, we're going to go over some of the more of the background and utilization of the medications that we use for opioid use disorder. As Dr. Meshke mentioned, my name is Wesley Gemin, Chief Pharmacist and State Opioid Treatment Authority for our department. I do not have any relevant disclosures. Some objectives for today, we're going to compare and contrast the recent drug trends and medications for opioid use disorder utilization, understand some recent legislative updates related to that, and understand some multiple factors that impact buprenorphine access and some proposed solutions. We do have a long way to go and a short time to get there, so I'm going to move briefly. If there are any questions, feel free to use the chat. We'll try to get that to those at the end. In addition to the recording, I do make these slides available. If you want to message either me or Dr. Meshke, we can get you the slides for you to review privately at your own pace. So start with some current trends, go over this sort of briefly. I feel like many of the people on the call here are pretty familiar with the situation that we're in regarding the number of overdoses that we are experiencing. So some recent national overdose numbers, we have broken the 100,000 mark as of 2022. So if you break that down, we're losing about 13 people to death per hour, given the current rate. So we still have a long way to go and definitely need to hit the gas pedal when it comes to our prevention and treatment services. This may also be familiar to those of you in attendance here, seeing the increase in deaths involving any opioid. As many of you may know, that the predominant opioid driving these deaths is our synthetic opioids like fentanyl. As shown by this chart here, where it's looking at prescription opioids, you can see that our efforts through provider education, safe prescribing limits, utilization of our prescription drug monitoring program, or CSMD here in Tennessee, we are seeing a significant increased number of deaths using prescription opioids. This graph is pretty interesting because it looks at just heroin. So you can see the dramatic drop off in overdose deaths associated with heroin. As many of you may know, that fentanyl has by and large replaced heroin. When speaking with a lot of my providers at the clinics that I oversee, whenever they have a new admission and their drug test only shows positive for heroin, it's a real big surprise. They're like, wow, where did you find just heroin? I didn't even think you could get that anymore. Unfortunately, the situation is dire enough that we have some providers reminiscing, like, oh, you remember when we only had to deal with heroin? And now we're having to deal with fentanyl, which is much more potent, strong, much more difficult to treat. It's more difficult to stabilize patients with fentanyl use disorder. Not to mention other adulterants that we are now seeing in fentanyl, things like xylazine, medetomidine, which is a topic of another presentation. So, uh, treating individuals with opioid disorders is getting more difficult and more complex. So we have some providers reminiscing, like, remember when it was just heroin? What we were seeing in Tennessee, we just see a very slight increase in overdoses. So we're hoping that we're seeing a plateau. At the national level, some of the more recent numbers have seen a slight decrease. There's a lot of efforts trying to analyze the efforts that contributed to that decrease. Tennessee and West Virginia, however, did not see a decrease. We saw about a 0.3% increase. I'm very hopeful that we will see a decrease next year. But if anything, this should motivate us to really push efforts that we are currently doing, continue to innovate. The numbers are still too high. This really is not any sort of data that we should sort of like rest our laurels. In addition to fatal, I do want to mention the non-fatal. So in 2022, this is according to the Department of Health's prescription drug overdose database, We had over 26,000 non-fatal overdoses. So these are 26,211 opportunities or second chances. These are opportunities where our system can intervene and hopefully get these individuals started on their path to recovery. So yes, while there is an unfortunate amount of deaths, the unnecessary to the treatable disease, we do want to keep in mind that there are tens of thousands of opportunities for us to intervene to help someone get on their path to recovery. So one of the ways that we do that while we're here today is medications. This is not to disqualify or discourage any other forms of treatment. However, medications, I put it over the stapler there. It really does help someone stick to their recovery plan. There are lots of benefits to using medications. It's not the only tool in the toolbox, but it's probably one of the more significant tools that we can use. I did want to start here briefly talking about the DSM criteria. So this is the diagnostic criteria to diagnose someone with opioid use disorder. And although it's very technical and textbooky, it is really important for reasons I'll explain in the next two slides. So some of the diagnostic criteria includes using opioids in larger amounts, having unsuccessful efforts to cut down, spending a great deal of time, having cravings, failing to fulfill major role obligations at work, school, or home, having social and interpersonal problems, giving up activities that were once found pleasurable, using in situations where it's physically hazardous. You will notice that the majority of these diagnostic criteria are behavior based. The only two down at the bottom, number 10 and 11, is tolerance and withdrawal. That's more pharmacological. Tolerance is just having to use more of the substance to get that effect. Uh, you could say that I'm very tolerant to caffeine at this point. And then also withdrawal is that if you were to take that substance away, those physical and psychological manifestations of withdrawal, there's asterisks on those because those only apply if the substance is not a prescribed substance as part of someone's treatment plan. So, but other than those two, the rest are behavior based. Some of the biggest criticisms that we get about using medications for opioid use disorder, and we still hear this sentiment today, is that the maintenance opioid agonists like buprenorphine or methadone, we'll talk about here in a minute, is just switching addictions and patients should not be on them long term. However, research has showed us that if someone is maintained on treatment with medications for opioid use disorder, or I'll just call them MOUD from now on, has been proven to show normalization of functioning. They do not get euphoric or analgesic effects from, they do not get high off of maintenance medications. There's it says no or very little change in tolerance levels over time. They are effective when administered orally, no need for injection. They do relieve opioid cravings and that persistent desire to use opioids, and has minimal side effects. And that, on the other hand, if you were to force somebody off of taking medications for opioid disorder, oh, you're just switching from one addiction to the other. You're not truly clean. So whether it be from a facility systematic level or from peer pressure or family pressure, some individuals feel like they're forced to taper off of these medications when they don't feel ready. And when that does happen, evidence has shown a significant rate of relapse and increased risk for drug overdose. That's not to say that people have to be on these medications forever. However, forcing that tapering without any other clinical considerations has very significant negative healthcare risks associated with that. And so when you're thinking about switching from one addiction to another, that's probably one of the most common negative stigmas against medications for opioid use disorder. You have to kind of think back to that diagnostic criteria, that the majority of that diagnostic was related to those behaviors, using more. Um, uh, I'll just go back to it real quick. So using larger amounts, unsuccessful efforts to cut down, spending a great deal of time to obtain the opioids, having cravings, failing major role obligations. And when using medications, those criteria do not exist. So if you say switching from one addiction to another, by the textbook definition, yes, they have a diagnostic criteria for it, but they are not exhibiting any of these addictive behaviors. So switching from one addiction to the other, not only is it colloquially or connotatively incorrect, but also by the definition is incorrect. So it's helpful for people to understand the difference between dependence. Again, I mentioned caffeine earlier. We can become dependent on any substance, sugar, caffeine, nicotine, etc. The addiction is when you factor in those behaviors associated with using that substance. And so using medications has shown to be very effective for addiction by not only controlling those physical and psychological symptoms internally, but also helping return to normal behavior. So this comes from the VA's academic detailing program. They've done significant research and review on the use of opioid agonist therapy, or buprenorphine or methadone. And even in their detailing for their providers, they're educating their providers that these medications do decrease HIV or really any sexually transmitted infection risky behavior. It has been shown to actually decrease drug-related criminal behavior. They've even done studies where looking at things like methadone clinics or buprenorphine providers actually show it decreases drug-related crime in the area that these facilities exist. It doesn't really affect non-drug related behavior, but if you look at drug-related crimes, it decreases in the areas where these medications are more available. We mentioned before that it decreases cravings, prevents withdrawal, and it decreases any illicit opioid use. So going into the medications specifically, we have three FDA approved medications. They're in different formulations, but the three active ingredients, the one on the left is naloxone or naltrexone. These medications work by basically binding to and cutting off that opioid receptor, basically cutting off that switch, turning that light off. The one in the middle is buprenorphine. It works a little bit differently by lighting it up partial amount. So they call it a partial opioid agonist. It very tightly binds to that opioid receptor, but only lights it up part way. The other third medication that we use is methadone, and it lights up that light bulb all the way. It is a full agonist. It binds to the opioid receptor and has full activity. So another way to sort of represent this on this chart that looks at the percentage of mu receptor intrinsic activity, that's your opioid receptor. And then looking at the medication dose there on the x-axis, you can see that methadone almost has full receptor activity. Buprenorphine is only a partial agonist. It only lights it up about halfway. And then naltrexone fully antagonizes or basically turns off that receptor. So why would we use medications? What are the purpose for MOUD? And what we use medications for, of course, is to allow that reestablishment of those reward pathways in our brain. So individuals with substance use disorders often may have disordered thinking or abnormal, non-culturally appropriate behaviors, and that sort of stabilize those brain pathways when they're not going through cycles of euphoria and withdrawal. It does take a good amount of time for the brain to heal from that. But medications are very helpful. Medications help restore that emotional and decision-making capacities. Your brain's manager, that prefrontal cortex, that helps understand responsibilities and consequences of our actions. That can take a couple of years, but those do end up getting restored, where individuals have more insight into making more responsible and positive healthcare decisions for themselves. We know that it controls symptoms of withdrawal, which is one of the main reasons people relapse, is because they have these cravings, or if they're hurting from withdrawal, they may be more enticed to reuse opioids, so it blocks that. One thing is that it blocks the reinforcing effects of ongoing opioid use. If someone is on a medication like buprenorphine, or really any three of them, naltrexone, buprenorphine, or methadone, if someone were to use fentanyl or heroin on top of those, they really do not get the euphoric effect. Most people tell you like, oh, it was a stupid decision and it ended up being a waste of time anyway because I didn't even feel it. So it can block those effects of ongoing illicit opioids. It does help promote patient engagement and recovery-oriented activities. So individuals that use medications are more likely to be retained into treatment, getting counseling and getting connected to a recovery ecosystem. And so when medications are coupled with behavioral interventions, they learn how to better appreciate natural, healthy rewards, healthier activities, some positive healthcare interactions, reducing their reactivity to stress and negative emotional states. So, whereas typically most individuals who do use drugs, when they're incredibly stressed, depressed, their go-to is always go use drugs to help so they don't have to feel their feelings anymore. So when coupled with behavioral interventions, uh, they're equipped with more tools to be able to handle those stresses and anxiety without the use of illicit substances. This is a really great analysis. If you're familiar with the National Academies of Science, Engineering, and Medicine, they do deep dives into various topics and come up with basically like key findings and what does the research at the time actually show. They have really great reports on using cannabis for pain. I think they just released one about cannabis regulations in different states. So a variety of different topics, but the one for medications for opioid use disorder came out a couple of years ago, but their key findings are still very prescient today. The first one being is that opioid use disorder is a treatable chronic brain disease. We still have individuals that believe that it's a moral failing or it's a failure of the will of the individual. But obviously, the research shows that it is a preventable, treatable, but it also is a chronic and relapsing brain disease. Just like other common conditions such as diabetes, high blood pressure, et cetera, but it's a disease of the brain. Second conclusion is a no-brainer for us that medications are very effective. They intend to keep people in treatment longer, and individuals who use medications for opioid use disorder compared to other treatment styles for addiction, that the medications typically tend to be more effective than interventions that do not use medications. Third one is that long-term retention is associated with improved outcomes. In fact, if you look at any study that looks at mortality, frequency of unfavorable drug screens, if you kind of think of any outcome that you would look at when treating someone with opioid use disorder, that retention in treatment has been the only one that has consistently been statistically significant to improve outcomes is retention. So the type of medication, the dose of medication, other interventions all have somewhat mixed and it really doesn't matter you use one or the other. But the one very clear outcome that has been proven to improve outcomes has been retention in treatment. The longer someone's in treatment, the better outcomes they're more likely to have. The fourth one is that if there's a lack of availability or utilization of behavioral interventions, it's not a justification to withhold medications. So we should not make medications available only if they participate in other behavioral interventions such as counseling, psychotherapy, case management, etc. Medications do help, obviously help them live, and these interventions help them live even better. But you should not throw the baby out with the bathwater and withhold medications because someone either doesn't have access to or refuses to participate in things like counseling. Another conclusion is that most people who benefit from MOUD do not receive it. And even though these guidelines came out a couple of years ago, the most recent National Survey of Drug Use and Health have found that of the individuals, I think it's like 2.5 million individuals who self-reported as having OUD, only 36% actually received treatment, any treatment, and only 22% received treatment that included medications. So there are a lot of barriers that we'll talk about later, but that was one of their findings from this report. The other thing is that medications are effective regardless of the treatment environment that somebody is in, and that withholding medications based off of their environment, whether it be if they're in a housing project or if they're incarcerated, et cetera, is that medications should not be withheld because of that person's housing, living status. We do know that there is still a long way to go in making these medications available in housing projects and in criminal justice settings. So there's a lot of activities at the state level trying to increase the access to medications, not just prisons, but also jails, recovery housing programs, et cetera. And so the last one that has that confronting the major barriers is critical to addressing the opioid crisis, which is a really great segue because next we're going to talk about some utilization and some barriers that might affect utilization. But there are several barriers. It's going to take sort of a whole state approach, a whole nation approach to address all these barriers because some of them are very nuanced. There's still a lot of stigma towards the use of medications, not just with people that don't have the disorder, but even people in the recovery community themselves. We find that some individuals who are in recovery from addiction in the past, without using medications, often stigmatize people who try to find their recovery with medication. So you still see a lot of, oh, you're not really clean if you use these medications, you're not really in recovery. This is just a crush. We still see a lot of those things everywhere. There is a lack of professionals that make medications available. We'll talk about that here in a minute. And there are a lot of regulations and restrictions that are not present on other drugs or disease states that do exist for this one that is also a barrier. So moving on to utilization, where can I find a provider? So this is a shameless plug for our department's website. If you go to tn.gov/behavioral-health, we have a licensing page, and the very first option is to find a licensed provider. We have two different options. One of them is sort of a dashboard like you see on the screen here. You can hit the little drop-down box and find the type of treatment that you are looking for. For example, I have clicked here, opioid treatment programs that primarily offer methadone, then office-based opioid treatment facilities, or we call them OBOTs. They primarily offer buprenorphine prescribing. And you can click on the city, you can click on the county, and you can find those individuals that have a license with us to offer those services. In addition to the dashboard, we also have just a regular database search. For this license category, you can click opioid treatment program, city, county, zip code, whatever, and it opens up a PDF report of what you're looking for. So how many do we have? So these are just licensed OBOTs on top here. There are lots of providers and facilities that offer buprenorphine, but it's not to the degree in which they need to be licensed by us. So we don't license hospitals as OBOTs. If you have a primary care provider that has thousands of patients and a handful are on buprenorphine, we're not going to license you. So these are just licensed OBOTs, or sometimes referred to them as Suboxone clinics. Primarily outpatient provider offices that specialize in addiction and prescribing of buprenorphine. We have 191 facilities across the state. I would say probably about maybe like about 2/3 of those are located in East Tennessee. When you're looking at OTPs, those are also referred to as methadone clinics. These are the only clinics that are authorized to use methadone for opioid use disorder, and we only have 22 of them. And you can see that there's obvious gaps in the state, especially, Cumberland, for example, that, I mean, you're looking at driving 2 hours in one direction just to be able to access methadone for opioid use disorder. So you can see here that the distance and the availability of these facilities can be a barrier. These cannot be prescribed. They cannot be done through telemedicine. Methadone can't. So still have significant gaps in our state where this should be made available. When looking at the prescribers of buprenorphine, so this is using CSMD data. So this only counts providers that are writing prescriptions being filled at pharmacies that are being reported to the CSMD. So it may be slightly higher, but it's a pretty good picture. So here you can see the last 3 years. You can see a steady increase, especially in our nurse practitioners, physician assistants, our advanced practice providers. You can see a steady increase, making it more available to more people. Seeing a little bit of plateau in the physician colleagues there. To give you an idea of how many prescribers there are in our state. This is a graph looking at the numbers of individuals enrolled in a methadone program or an OTP. Back in June of 2020 is when TennCare started paying for methadone at an OTP again, and we have just seen a steady increase ever since. So looking at the same time period as above, or the previous slide, we started in 2022. But if you were going to go back to like 2019, early 2020, that number would only be around 5,000. So in the past 5 years, and a lot of it has to do with payment and availability, access, especially through TennCare and other third-party payers, that the number of individuals enrolled in a methadone clinic has nearly doubled in the past 5 years. So going over some barriers, SAMHSA had done a roundtable about a year and a half ago, maybe 2 years at this point, getting all the stakeholders together to try to identify what the barriers are. And this was specific to buprenorphine. And so they identified several areas of concern related to preventing access to buprenorphine, the primary one being stigma. Others are patient barriers. These are like patient-specific barriers. They can't afford it, they can't drive, they don't have transportation. Those are barriers that are specific to that individual patient that prevented them from being able to access it. Another reason is that this buprenorphine is an opioid. It works a little bit differently, but it is still technically an opioid, and it is in the same classification as other opioids. So when you're looking at reports, thinking more like wholesalers that sell drugs to pharmacies, that these drugs are included with other opioids. So when you're looking at how much opioid dispensing is going on, how much opioids are being sold to individual pharmacies, that this is wrapped up in there. Because a lot of the recent settlements and lawsuits, wholesalers that provide the medications to the individual pharmacies are really cracking down on how much opioids that they are sending to pharmacies because they were criticized and had to settle that they did not do enough to identify red flag orders and restrict the sales of pharmacies that were obviously supporting pill mills and things like that. So they're severely restricting the amount of opioids that they sell to pharmacies, but the need for buprenorphine has never been higher. And so what happens is you have some pharmacies that say, sorry, I cannot order anymore because my wholesaler says I've hit some arbitrary limit. And it's because that limit has other opioids that are more used for pain, like oxycodone, is in the same algorithm. When another limitation is fear of violating rules, there's obviously been a lot of information in the news and the media about DEA enforcement actions. You have doctors being taken down, losing their licenses, pharmacies shuttering. because of DEA investigations and allegations. And so, not just on the pharmacy side, but also on provider side, because there are so many more rules associated with buprenorphine than other disease states and drugs, it's easy for them to say, I'm not even going to mess with it. I know there's a lot to it. I know there's a lot of rules. I don't want any undue attention from regulatory authorities. I'm just not even going to do it. Another thing is due to decreased reimbursement to pharmacies, if you consider things like drug discount cards, decreased reimbursement from insurance companies, that especially independent pharmacies will report losing money on every buprenorphine prescription that they dispense. I believe the participant um, here from the independent pharmacy said on average he loses about $10 a prescription. And so that may be another reason some pharmacies do not want to stock it, because they lose money on every single one of them and on top of everything else. So to help address some of these barriers, especially on the pharmacy side, we still see a lot of complaints in our state about pharmacies either not making it available or having very rigorous policies around dispensing it. That the National Association of Boards of Pharmacy, or NABP, worked with the National Community Pharmacists Association and the FARM program, Pharmacy Access to Resources Medication. It's a really great program based out of Texas. Develop these guidelines. And we did have Tennessee representation on these guideline committee. In fact, one of my employees was on this committee. Several pharmacists from Tennessee, providers from Tennessee, a director of a nonprofit here in Tennessee was all involved on the committees that created these guidelines. So, a couple of recommendations we'll go through real briefly. One is that pharmacists should maintain a sufficient supply. That's what we hear a lot, is that some pharmacies just aren't carrying it, or they don't carry enough of it. We have some pharmacies that hit these arbitrary pharmacy wholesaler limits. Say, hey, I really wish I could dispense it to you, but I'm at my limit, which means I take it away from somebody else. And if more pharmacies carried a sufficient supply, that would then distribute those patients across a wider market where these single pharmacies aren't hitting these limits. Number two is that pharmacists should use their prescription drug monitoring program, or CSMD, when making informed decisions about buprenorphine. Early refills is sometimes an issue that we hear from patients. Some pharmacies don't even fill controls early, even like 1 day ahead of time. But this is more just recognizing that patients are people too. Things happen. Their dose could change. They could lose something. Even if you have a concern, we'll get to this later, but you should be collaborating with that prescriber to address those concerns. And there may be some legitimate reason somebody needs to fill theirs early, just to have sufficient documentation. Another one is telehealth. I actually just heard today that there's a pharmacy company that's looking to impose policies restricting filling controlled prescriptions through telehealth. And I think it's more that question of legitimacy. Um, I'll talk a little bit more about telehealth here in just a minute. Monoproduct, especially here in Tennessee, we actually have a state law that other states do not have, that say that monoproduct can only be used if the person is pregnant, nursing, or have an allergy or hypersensitivity to naloxone. But buprenorphine monoproduct is just as effective and likely isn't being diverted at any higher rate than the combination product. But that pharmacists should just be aware of that. Number 6 is long. I'm not going to read all of it, but basically, pharmacists should do everything that pharmacists already do when it comes to dispensing buprenorphine, counseling on them. What can they expect? What are the adverse effects? Do they have naloxone available? Do they have any medications that might have a drug interaction? Do these individuals have a way to safely store these medications? It's really no different than what we would counsel somebody on any medication, especially controlled substances. So it's unfortunate that it's got to be said here, but some people, it's there for completeness, I think. Most pharmacists should be doing this. If anything, it's a reminder. And this is a big one for me. This is care coordination and prescriber communication. Almost all the complaints that get reported to me, they have not even talked. I get complaints from pharmacists, I get complaints from providers, and majority of the time, they've never talked to each other. And so I'm glad to be a facilitator, but if these individuals were just to communicate and work through, like, what are the issues here? Can we address those issues together in a collaborative, non-confrontational way? Resolves vast majority of the complaints that I receive. And so I encourage pharmacists and providers to have that sort of open line of communication between each other. Pharmacists can let providers know if there's any uh, red flags, like, hey, this person started going to a pain clinic and it's not from, were you aware of this? Or, hey, this person came in and they appear to be intoxicated. I just wanted to let you know, maybe you need to reach out to them and have them come in. Or this person was really tearful when they came into the store today. I don't know if they've met with their counselor recently, but they seem to be something going on. There's a really great information that can be shared. Same with on the provider side. Nothing preventing, like, hey, pharmacist, man, I'm about to send this prescription. Let me tell you about it because it's got a funny story. Um, Filling it early for these reasons, or yeah, I'm having to use this drug. Yeah, I'm prescribing a benzo, but it's because I'm trying to get them off of their benzo they were using. Anyway, it's just nothing but good can come from a good collaborative relationship between the prescriber and the dispenser. Last one is stigma. We're doing a lot of education, like what we're doing here today. I'm doing similar talks to the UT update. I'm doing similar talks to the Tennessee Pharmacy Association. I've done similar talks for Tennessee Society of Addiction Medicine. So the more education we get out there, the better to reduce that stigma. And then the last one that they had listed is employer oversight. We know, especially in the big chains, that there are companies that put in policies and stuff that further restrict professional clinical decision making. And so these guidelines are really meant for those organizations to allow individual pharmacists to use their professional discretion with documentation when deciding when to dispense and what's appropriate. The big thing from this guideline, if you were to take away anything, is ditch the red flags and adopt the yellow flags. Too many times have we heard pharmacists refusing to fill a prescription because of a red flag, whether it be distance or unknown prescriber to the pharmacist. The really red flags should be more like yellow flags. They're just reasons for you to ask more questions or to try to contact the prescriber or actually have a conversation with the patient, because many of those can be explained. A lot of pharmacists, when they're trained about red flags, if they receive one red flag, then the answer is no. So trying to do more yellow flags, ask more questions. There's probably a lot of reasons why things are the way they are. For sake of time, we do have Tennessee guidelines. They are very specific to Tennessee. They've been adopted by the Board of Pharmacy and Board of Medicine and Board of Nursing, et cetera. And we have a section for pharmacists in the Tennessee buprenorphine guidelines that make very similar recommendations. But for sake of time, we'll go through the very similar to I just went through with NABP. So recent changes. One of them, it's not as recent, but up to 2018, only physicians could prescribe buprenorphine for opioid use disorder. And since 2018, and about every other year or so, there have been new exceptions being added to allow nurse practitioners and physician assistants to prescribe buprenorphine. Some of those exceptions are that they can only prescribe in certain clinical settings. For example, a nurse practitioner may only be able to prescribe buprenorphine in the licensed OBOT. I mentioned we had almost 200 of those. They can only prescribe if it's an FQHC, Fairly Qualified Health Center, or a community mental health center. And just last year, they added teaching hospitals. So Vanderbilt helped shepherd that bill last year that if you're an advanced practice provider in a teaching hospital, you can now prescribe it. And each of those settings has additional restrictions, such as you can only prescribe up to 16 milligrams, you can only treat up to 100 patients at a time, you have to take 10 care, too many to list here. But if you want that reference, be glad to give it to you. We did talk a lot about telehealth. As far as Tennessee, the limitations on prescribing telehealth, buprenorphine by telehealth, that again, you have to be a licensed OBOT, you have to be an QHC, you have to be a hospital, or you have to be a member of TennCare's specialty network called BSmart, their buprenorphine specialty network. If you're not part of one of those, you cannot prescribe buprenorphine by telehealth in Tennessee. One change that is coming up right now, methadone use at a methadone clinic is not reported to the CSMD. That is due to federal, that has been recently changed, but federal privacy laws regarding records of substance use abuse records. Right now, they changed the federal law that says that methadone clinics can report if the state requires it. 2 years ago, the state passed a bill that does require it, but not until the Department of Health makes rules on how it should be done. So the state law says, yeah, you have to do it, but not until the Department of Health promulgates rules on how it should be done. And so until those rules are effective, it is actually illegal for a methadone clinic to report methadone use to a CSMD or any state's PDMP. So, but once the Department of Health makes those rules, you'll start seeing methadone in CSMD reports. Briefly mentioned xylazine at the top of the presentation. This is an adulterant that is being added to fentanyl. Goes by the trade name of Trank or Trank dope. It is a veterinary sedative, literally a horse tranquilizer that is being mixed with fentanyl to basically prolong the effect of that fentanyl, making that nodding effect last longer. It has terrible side effects that I don't have time to get into here, but causing severe wounds. And so we passed a law. Technically, xylazine is not a controlled substance, it's not an opioid. However, if you are in possession of xylazine, or if you're selling it or manufacturing it, and you're not a veterinarian who's going to use it for a horse, um, just possession is a misdemeanor, but manufacturing, selling, possessing with the intent to manufacture or sell is a felony. At the federal level, just go over a couple handfuls here. In the beginning of 2023, you used to have a waiver to prescribe buprenorphine outside of the OTP. They called it the data waiver or the X waiver. It was basically the same number as your DEA number, except it had an X in front of it. It had certain training requirements, and you had to do some paperwork with the federal government. But early of 2023, that was removed. So you no longer need any special waivers to prescribe buprenorphine. As far as the federal government is concerned, so long as you have the authority to prescribe Schedule 3 controlled substances, you can prescribe buprenorphine regardless. Again, there are some Tennessee laws that further restrict that, but federally, it's just like any other Schedule 3. Another recent change is that they've changed the standards for opioid treatment programs or methadone clinics. Probably one of the biggest changes is how much medication that they are allowed to take away from the clinic. So previous to this, really prior to COVID, because they just made their COVID waivers permanent, but prior to COVID, when you first started at a methadone clinic, you had to go every day. You got your dose at the window every day. And now, since COVID, and now with these new rules, individuals are able to get take home or carry out medications sooner in treatment. COVID was a great real world experiment that had shown that even with the increased amount of methadone that they were able to take away from the program, there has not been an increased rate of diversion of that methadone. So they felt comfortable making those permanent. The 3-day rule is traditionally used by emergency rooms or hospitals. This allows a practitioner in a hospital-based environment to dispense up to a 3-day supply of a controlled substance, i.e. buprenorphine or methadone. to a person for treatment or detox while their arrangements are being made for them into treatment. So if someone shows up to the hospital after an overdose and you got them connected to a local provider and says, hey, we can see them tomorrow or we can see them the next day, you can give them medications to last up to 3 days. This previously was in the law, but you can only do 1 day at a time. So previously, it said up to 3 days, but not more than 1 day at a time, which meant that people had to come back to the emergency room every day to get their 1 day supply for no more than 3 days. That has since changed. You can do all 3 days at once now. One that might be coming up, this is not effective, but it is very exciting, called the Modernizing Opioid Treatment Access Act, would allow extended telehealth flexibilities for initiating medications, and it allows practitioners at a opioid treatment program or methadone clinic to be able to prescribe methadone to be filled at community pharmacies. Right now, you cannot do this. Methadone for opioid use disorder can only be dispensed at a methadone clinic. This is obviously another restriction, it's another barrier to access, et cetera. There's been a couple of pilot programs in other states, and there is currently, it's being proposed, it's not finalized yet, but if it goes into effect, our pharmacists might now be getting prescriptions for methadone for addiction. And then this, I literally just put in today, and it's my last slide, is just yesterday, day before yesterday, the DEA has announced a permanent change to their telehealth rules for prescribing buprenorphine. Technically, it's Schedule 3 through 5 drugs approved for opioid use disorder, but the only drug that meets that definition is buprenorphine. So these are finalized rules that go into effect soon. I don't have the effective date on me, but they were just released, that a practitioner may prescribe buprenorphine through the means of telehealth, including audio only, not even a visual component, just on the telephone. You may prescribe for up to 6 months without having an in-person examination. But after 6 months, you either have to see them in person or meet what they define as the practice of telemedicine. So I put that in quotes because it's a defined legal term to the DEA. Technically, I have the reference there for you, 21 USC 80254. Technically, to meet that definition, the person you're treating, there's like 7 different conditions. One of them being that the person you're treating is physically located in a registered facility, like a hospital or a clinic, or the person's in the physical presence of a DEA registered practitioner. For example, if the person's literally sitting next to, say, a nurse practitioner that has their own DEA registration, but they do telehealth with a physician colleague, that's technically a practice telemedicine. You don't have to have the in-person examination. Indian Health Service, if there's a pandemic and if you have special registration that's not available yet that they're working on, then you don't have to have the in-person examination. But unless you meet those qualifications for how they define telemedicine, you have to have an in-person, the practitioner themselves have to have an in-person examination to continue prescribing buprenorphine by means of telehealth. So that was a lot. We went over it very quickly, and I'm sure I took a few extra minutes, so I apologize to my co-presenters. I'm going to quit sharing so I can see the chat. Okay, seeing no questions right now, and for sake of time, Dr. Meshke, I think we can move on. I'm going to remain. So if you want to direct message me in the chat or send me an email or reach out to Dr. Meshke to reach out to me, I encourage you to do so.
Dr. Gavin, thank you so, so much for the wonderful presentation and for all that you shared. I would just like to say, is there one burning question before we move on? Because we are running a little bit late, but I also appreciate there's a lot of information here. Okay. Well, seeing none, I am then going to be turning the floor over to Dr. Torvell. Dr. Gammon, thank you again. Jennifer, the floor is yours.
All right, so I am going to talk about a program that we have through the RCOR grant. It's a medication for opioid use disorder mentoring program. And the purpose of the program is to expand access to medications from opioid use disorder through clinical training and mentoring of future providers. So we just heard a lot of information about some of the barriers to people accessing MOUD, one of which is the stigma that's encountered, both stigma, the provider side, the patient side, but educating future providers about how to take care of people that have a substance use disorder outside of a addiction treatment environment. So what I mean by that is emergency departments, OBGYN offices, family practice clinics. All future providers are going to come in contact with people with a substance use disorder, whether they're in addiction treatment or not. So we want them to have knowledge about how to not only treat those patients, but how to interact with them and to understand the disorder as a disease and everything that goes into providing comprehensive care for these patients. So these are the program objectives. I'm not going to read them to you, but I wanted to have them in there in case Lori shares this out with you. You'll have our objectives for the program. So the participant requirements, we want these future providers. So we target MD, PA, physician assistant, and NP students, nurse practitioners, in any type of program. So for NPs, they can be going into family nurse practitioner, psych mental health nurse practitioner, PAs, again, emergency medicine, family practice. MDs, we've had, you'll see in a little while, but we've had quite a variety of specialties from the MDs. So we target the students and they're required to carry their professional liability. They do 40 hours at a clinical site with a prescriber of MOUD. And we do put them into addiction treatment clinics. We want them to see complete wraparound care, not just the prescribing of medicine, but the counseling, the certified peer recovery support sessions, the methadone window distribution, everything. So we put them into addiction medicine, but knowing that they aren't probably going to work in addiction medicine when they graduate. The students that are going to work in addiction medicine when they graduate, they do several hundred clinical hours in addiction medicine. These are for students that want to learn how to interact with this patient population, but don't plan on working in addiction medicine. So we also have them do a harm reduction volunteer session. And the reason for that, and we have them do that after they do their hours at the clinical site, but once they learn how to provide addiction treatment, we want them to just interact with people prior to being in treatment and recovery. We want them to talk to people who are currently using drugs, to hear about their needs, to hear about the barriers to them getting treatment or other services. And it has proven to be very valuable. So that's all we require of them prior to the data waiver. I guess I don't know the word I'm looking for. The removal of the data waiver requirement. We did have them get that data waiver as well so that they would be able to prescribe. But since that's now been removed, we no longer require that, of course. So the mentoring sites that we use, again, addiction treatment, we use the Cedar Recovery locations in South and East Knoxville. So these are in Knoxville, but they are in rural areas of Knoxville. So one is on John Sevier Highway. The other is in a rural part of Strawberry Plains. So that's something else, we're targeting rural healthcare access with this program. want students in this program that plan to, well, one, want to learn how to care for people in rural communities, but also plan to work in rural communities upon graduation, especially in East Tennessee. So even though those clinics are in Knoxville, they are in rural areas. The Cedar recoveries, those are typical, sorry, just let him in. They are typical clinical hours. So Monday through Friday, 9 to 5, they have counseling, peer support, all the wraparound services, case management. They have psych mental health nurse practitioners and do some co-occurring mental health treatment. So very wide range of services. The New Hope Treatment Center, that is in Newport, very rural area. It's one of the few distressed counties in our state. This is a clinic owned by Dr. Stephen Lloyd. He has hired a new medical director. That is the only MD, and it is an FNP that is their primary prescriber, and she's fantastic. They also have counseling and wraparound services and all of the things. They prescribe methadone. So when we're thinking about placing students in this clinic, we have to be a little cognizant about the time. They typically open from 6 a.m. to 11 a.m. So it's difficult to do trainings for people that have children, people that have other jobs or courses or classes during the evening hours. So a little bit difficult for this one. But again, they get to see the additional prescribing of methadone. And then for our harm reduction volunteer sessions, we pair them up with either Choice Health Network. If they do that, they will typically go to the Knoxville fixed site, but we have had a few that went with the mobile unit to their Newport location. And then we have it open for them to be able to go to Live Free Claiborne, which is a fantastic harm reduction program that operates out of the Hill Church in Tazewell, Tennessee. Again, very rural area. We only had one, I think one from this round of students that went to that particular location, but that's a fantastic site. So when we place the students there, we want them, like I said, to get an idea of everything that happens in the clinic, but we do want 75% of the time to be spent with the prescribing provider. We want them doing intake assessments. We want them, seeing people that come in day one. And we also want them seeing patients that have been there longer, so 90 days or out, and kind of see what that looks like, the difference between their treatment plans as well as just their overall health. So 75% with the prescribing provider. And then if they want to do any of these other activities, we limit it to 2 hours. But we do want them to have the opportunity to see what the other people in the office are doing. So what this program, we are providing a stipend to these students. This does not fit into their other clinical hours, and we're going to talk a little bit about the barriers in just a second. But because it is not part of their school curriculum, they're spending this time on top of the other hours they have to do. So say you have a family nurse practitioner. Well, they're going to do 700 clinical hours, and those are going to be in a primary care office, a pediatric clinic, a little bit in an OBGYN office. They have a lot of requirements. Addiction medicine is not one of them. And so this program, these hours they have to do, is on top of all of the other clinical hours that they already have to do, which is quite a barrier. So what we want to do is, I feel like I did skip one. Sorry about that, guys. I skipped a page. I want to tell you a little bit about the students that we just had go through this program. So we had 4 psychiatric mental health nurse practitioners from the UT Knoxville College of Nursing. And again, I do an interview on Zoom, face-to-face, or in person with all of the students before we place them. Again, we want to ensure that they do plan to practice in Tennessee, in East Tennessee specifically, in rural areas, and are willing to, if they have the opportunity, to provide MOUD to their patients. So we had 4 psych mental health practitioners. 3 went to Cedar Recovery South. 1 split their time between Cedar Recovery and New Hope. It was a little complicated to coordinate, so we didn't do that anymore. We kind of made them pick one or the other. I hated to do that because I would love them all to get experience with methadone, but that was a little bit complicated. We had 1 go to CR East. That one has not yet been able to complete their hours. They had some childcare issues, so if they are able to complete, we'll finish them out. And then all 4 of those completed their hours with Choice Health Network. I think 2 of them in Knoxville and 2 in Newport. And then we had 7 Quillen College of Medicine students. 5 went to New Hope. They like to be as rural as they possibly can. They like to do these hours during their, I believe it's their 2nd year of med school in their rural track. 1 went to CR South. That one was actually a retired MD, so long time practicing MD. She was volunteering some of her time in a clinic in I forget where, in rural Knoxville, but she had a lot of patients with hepatitis C and just wanted a better understanding of how to interact with those people. A lot of them, we know that is pretty common with people who use drugs. So she wanted to learn more about just people who use drugs, people in recovery, addiction treatment, and it was a fantastic opportunity for her. We had 1 at CR East, 6 went to Choice Health, and then 1 went to Live Free Claiborne. 4 of these MD students were planning to practice family medicine. The current MD worked in gastroenterology, again, hepatitis C treatment. 1 was going into emergency medicine, and 1 was undetermined. He was thinking neurology, but then when I did do an exit interview with him, he was considering addiction medicine. So very much liked this experience. So sorry about the jumping back and forth. Going back to the sustainability and expansion. So because they have to do these hours outside of their other school curriculum, we do give them a stipend of $500. When our grant period is over, we are not going to be there to coordinate them going to these clinics. We're not going to have funding to give them $500. And that money is really to compensate their time and travel. Most of these students will stay in a hotel, so they don't have to drive back and forth to get to clinic 5 days a week. They're typically do a 40-hour week at a time, or they'll be going back and forth 1 day a week. So that just helps with their travel and compensate a little bit of their time. So what we want to do is we want these clinics to continue to mentor these students beyond our grant period. So what I've been working very hard at is trying to establish these clinics as a permanent clinical site for these programs. And I am telling you, it is complicated. The barriers, the clinics are open to it and the schools are open to it. Where we run into problems is with this list of barriers. So we had another methadone clinic that we tried to place students at, and it got really messy. They wanted a drug screen, a background check, all of these things. The other clinics we work with don't require that because the school requires it. So as long as they're up to date with everything and their school allows them to be in a clinical setting, they will allow them to come to the clinic. This other clinic would not. They wanted to do it all themselves, and it became very cumbersome. So we were not able to continue with that clinical site. So that can be a barrier depending on the policies at each medical office location. The formal agreements with the schools and the clinics, they are fairly basic agreements. But if anybody has had to have anything go through a legal department at a major university or these clinical organizations are fairly small, so hasn't been too difficult on the clinical side with the agreements, more so with the schools. They write the agreements. If the clinics don't have any objections to anything in them, it's fairly easy. But if there's anything the clinics want changed, it has to go back through the legal department, and that can take up to months. So depending on how those agreements are written, really depends on the time that takes. It has taken me almost a year, and we are very close to having Cedar Recovery as a permanent clinical site for UT College of Nursing. It's taken almost a year. The required credentials of the providers, and this is one thing that was a very big barrier with the College of Nursing. The Psych Mental Health Nurse Practitioner program was only going to allow those practitioners to count these hours as clinical hours if they were placed with a board-certified addiction medicine doc, a board-certified psychiatrist, or a nurse practitioner, a psych mental health licensed nurse practitioner that had been in practice for over a year. The hard part was Cedar Recovery, they don't require, and this is not them, this is typical for any medical doctor office. They don't require their providers to be board certified in addiction medicine to provide addiction medicine. And what that means is they had a board certified OBGYN providing addiction medicine. They had one board certified in family medicine that is providing addiction medicine. So they were not able to place psych mental health nurse practitioners with those providers and have that count as part of their curriculum. That was a huge barrier. What we were able to do to get around it is have the non-addiction boarded docs serve as preceptors for nurse practitioners. No, I got that backwards. The addiction docs had to serve as supervising preceptors for the other providers that were not board certified. So then we have 2 layers of precepting, which gets, again, a little bit cumbersome. It was difficult to talk the addiction certified boarded doc into doing this, but he did agree. Once they got to that point, the trainings and the forms needed by the providers that they had to fill out was another layer and a big barrier. So I don't know how much work you guys do with physicians. They're busy. They don't want to do extra things. Getting these forms filled out and having these trainings done by them was difficult. We have one doc that still needs to do it, and then everything will be official. The other issue we've run into is the independence hands-on experience requirement. So we are in the process of the formal agreements have been signed with the Quillen College of Medicine and the New Hope Clinic. Where we have a problem is New Hope does not want the students providing any independent care for their patients. Completely understand that. This is a vulnerable population. These are students that don't have any experience interacting with this population. So I get that. They want this to be a shadowing experience only. The school is requiring there be some type of independence by the end of the 40 hours. And so they want them to start more of first couple days shadowing, but by the end, doing creating plans of care, doing patient visits alone, and then having the provider come behind them and check their work. That might be a deal breaker. We're still trying to have some conversations about this. But anyway, that's what we're trying to do. It's difficult. But I want to show you the feedback we've gotten. And even if we aren't able to sustain this long term for all of East Tennessee, we are really, I feel, making a big impact. When I talk to these students on the front end about their knowledge, and all of them are open to learning, which is why they apply to do the program. But just getting an idea of their base knowledge regarding substance use disorder, and then hearing their perspectives on the back end, this is greatly impacting stigma. even if it's not a lot of students, they are going to be providers in East Tennessee, and it is truly decreasing stigma. So these are some of the direct quotes from exit interviews that I've done with these students. This is regarding the clinical sites. Every single one of them was very pleased with the experience. None of them had any regrets. 3 MD students did report a desire for more independence. Other than that, there were no changes to the program recommended. Everybody loved the providers, and you can see there some of the feedback. That first one, rather than shunning people away, I will try to assist people in the ED. This student was currently a nurse in an emergency department and said that the way people were treated in the emergency department was so extremely different than what she experienced in the clinic, that she just couldn't even believe it. She's going to take that with her back to the emergency department, and that's exactly what we're trying to do. And then the feedback from the harm reduction portion, this is probably everybody's favorite part. They don't know really what to expect when I describe this to them and tell them that they're going to go here. But when I hear their feedback on the back end, they absolutely loved it. And a couple of them even asked if they could continue to volunteer there. Of course, I told them to set that up with a clinic, and they were in the process of doing that. So definitely combating stigma, definitely providing education. Long term, we'll have to see the outcomes, but I think that's all I have for you. If anybody has any questions, happy to answer those.
Much gratitude, Jennifer. Excellent, excellent work. I missed if you said this, Jennifer, but you've been doing this now for what, 4 years? Did we start this in the previous grant cycle?
We started it at the end. So yes, I think the last year of
Mhm.
a previous grant. Yes.
Yeah. So on to 4 years, and with the number of people that you've been reaching out to annually, I mean, you're making a pretty big dent out there, and I'm really pleased for all that effort. I am really curious, and I'm going to put this out there for Dr. Gemin or for Jennifer, Dr. Torbelt. You know, we've had issues with pregnant women having access to treatment and recovery services, and I am really curious if in your time in the field you have seen any tide turning. Are pregnant women gaining more access to MOUD than they have in the past? Because I appreciate this is the recommended approach for pregnant women with opioid use disorder.
There's not a lot. My absolute favorite is Dr. Jennifer Anderson. She was an OBGYN in Sevier County, saw a need with the high NAS rates to start treating people while they were pregnant, learned how to provide buprenorphine to pregnant women, started doing it, loved it so much that she ended up leaving her practice, went to Cedar Recovery, worked in addiction medicine at Cedar Recovery 5 days a week. Then she backed down to 3, got a part-time job as an OBGYN, and did both. And she is currently doing a fellowship in addiction medicine so she can get board certified. So she will be double boarded in OBGYN and addiction medicine. And we had, not in this cohort, but in the last one, we did have an OBGYN med student that we placed with her that was hoping to stay in East Tennessee. So we need more Jennifer Andersons. She's the only one I know. And of course, Dr. Lloyd was comfortable prescribing to pregnant women. He is not seeing a lot of patients currently, so we kind of lost him. I'm curious if anybody else knows of any. It's not a lot, Lori, not a lot that I know of treating pregnant women.
I'll just add that majority that I see is through referral. So it sort of can fragment their care. I have seen an overall general improvement. I remember pre-COVID, one specific case that will never leave me is we had a high-risk pregnancy. She was in methadone treatment in West Tennessee. Was able to go see a high-risk OB in Jackson, and they declined to care for her because she was on methadone. No coordination, attempted coordination. I mean, let me tell you, the OTP staff was just bereft. Like, we can't even get a hold of this person. We don't have the qualifications or facilities. I mean, so overall, I think it's better. Um, I can probably think of one or two very similar to Dr. Torville, where it's like fully integrated, somebody who does both. But most of the time I've seen is through referral and care coordination. Policy wise, which is my more my wheelhouse, is we have always had it in our rules that even if you have a wait list, you have to prioritize pregnant individuals. And then we have further, we're in the middle of revising our rules for OBOTs and OTPs. And we are furthering that to ensuring that there are no policy or administrative barriers for pregnant women, if there were any to exist in the first place. But doubling down on that policy.
Excellent. I am really grateful to hear that there's a little bit of movement in the right, caring, compassionate direction. So thank you for that. Any other questions before we move on to our final presenter today, Dr. Tyler Melton? Wonderful. Tyler, I turn the floor over to you. Thank you.
Absolutely. Let me get this pulled up. It's always so many clicks when you're waiting to be the one to get it going. Hopefully y'all can see this okay. So I'm here to talk about the Courage Pharmacist Mentoring Program. So this is a different arm of the Courage Project, and is in some ways kind of similar to what Dr. Torval was talking about, but obviously it's focusing on the pharmacist perspective. So we've got I mean, I'm saying this probably from partial, but a really good program team. Jared Vick is a wonderful pharmacist that practices in Newport, Tennessee. Just what Dr. Torval had said was one of the sites for their mentorship, and then also in Strawberry Plains. And so he and I serve as the mentors for these mentees, and we have a wonderful group of other individuals that have either helped develop some of the modules or who helps in the daily operations. So Rebecca Nieves and Lil Negeze, and then have Dr. Meshki, of course. So just wanted to frame that. So we just wanted to talk about Courage Pharmacist Mentoring Program, some of its successes and its overall effectiveness. This is a really exciting time because we have enough data that we can start reporting out some of the information, and we really have to frame it with like, what does opioid use disorder prevention and treatment look like in community pharmacy practice? And this is really well designed with Dr. Gimmon, with his perspective and what he had shared. I'm a community pharmacist by training for the majority of the time that I've practiced. So some of this is from experiences that I've had, and then also just based on our research. So for this program, we really wanted to involve in community pharmacists because they aren't often utilized for some of these OUD treatment opportunities, and they're highly accessible healthcare professionals that exist, particularly in all areas, but in rural areas as well. And so it kind of goes hand in hand when you have a chronic disease state that you're trying to treat and you're trying to promote accessibility, you would want community pharmacists to get on board with that. And having some of that seamless integration helps provide this continuity of care and can improve the overall road to recovery for folks. But there is a kind of a dark side in community pharmacy. This has been really fascinating for me to have had like the time for the last couple of years to look into and just see more of the research coming out. But there, as we know, for opioid use disorder, and as our other speakers have said, there's significant stigma associated with that. It's no different, you know, in the pharmacy realm. There's negative attitudes, and just like what Dr. Gimmon was speaking of, or people aren't able to dispense based off of some situation that could happen, or are not willing to dispense medications. It can really cause stigmatizing and these negative environments for patients, which is terrible for folks to experience. There was a study that was completed, you know, that's will be coming out for publication hopefully sometime soon. It was a secret shopper, and over 50% of the pharmacies that they surveyed within Tennessee either were unwilling to dispense MOUD or would not dispense MOUD, which is really disappointing to hear. So there's a lot of work that kind of goes into understanding what are these obstacles for MOUD, why do these things exist, and how can we address it. So the Courage Pharmacist Mentoring Program is meant to give some mentorship and then also some training for folks to kind of improve MOUD accessibility through addressing some of the obstacles that we have listed. Well, all of the obstacles actually is listed here. So there's more research than just like the previous secret shopper study I had discussed. There's others that corroborate, you know, the findings and research, particularly in Appalachia and community pharmacist resistance, sometimes to dispense MOUD for, I would say, like reasons that Dr. Gimmon had shared, and then also reasons that are rooted in things like stigma. And so that's understanding the intrinsic and extrinsic stigma and bias, excuse me, that exists within us, and more importantly, like how does that affect clinical decision making. So risk aversion, I hope I don't say your name too many times, Wes, because you did a really good job setting it up for this slide. So the risk aversion piece is kind of the things that he was discussing with clinical decision making. Like sometimes there are those things, it's known as red flags, that people have to resolve, and that has a pretty significant impact on folks' clinical decision reasoning overall. There's concern for diversion. It's been interesting when we've talked about this to folks throughout the state about what does diversion mean. There's two perspectives, I would say, from the community pharmacy aspect. One is that it's a controlled substance. So anytime we kind of talk about controlled substances, there's oftentimes a fear of theft. You know, and does that make them more likely to have like a robbery occur in their store? Thankfully, that's been on the decline over the last couple of years. But then also diversion, where the medications aren't used by the patient it's prescribed for, that it could be diverted to another individual. There's knowledge gaps for MOUD, particularly in understanding, you know, the terminology and the things that we're talking about in this presentation, and then common misconceptions. So, you know, you hear things like I can only have 30 patients at my store. In There's really no actual restriction for folks, but they may be referring to wholesaler limitations, you know, and things like that. So there are ways to work around some of this, and this is what we want to do with the modules. Dr. Gimmon was talking about the changing from a red flag, which is really a DEA term, to a yellow flag, to doing these conversations, and that's really what we focus on through this program. So it is a mentorship program to varying degrees with that mentorship depending on the cohorts. We have a service area of 6 rural counties. So in those counties, there's about 70 pharmacies total, 6 to 16 per county. We've had varying degrees of success for recruitment. Some folks are really interested in this and are kind of hungry to participate, and there's others that are not. And I hope I haven't colored things, you know, negatively with the last couple of slides. There are those kind of like bastions of hope, is what I would say, where people are doing, you know, the work and really wanting to assist patients with giving accessibility to MOUD. So we kind of have a recruitment of 13 folks thus far. Our goal was 20 total. And we built in some of these quality improvement evaluations, much to what Dr. Torval was talking about, and trying to shift things in real time as necessary to make it relevant for these practicing pharmacists. There's 2 of the service counties that have ropes coordinators, is what I refer to them, for naloxone. So we also include in component with naloxone on this. The structure is that it's all meant to be online and easily and readily accessible. What works really well for pharmacist training is to have things auditorily available. Hopefully I'm saying that correctly, where people can work the bench, like doing their kind of dispensing duties and some of the other clinical duties, and able to listen to things and then also refer back to it later when it's more of a calmer situation. So we have success in the College of Pharmacy with having CEs available that way. So we kind of focused on asynchronous formatting for the modules like this. So 8 modules we'll talk about later. Bi-weekly mentor check-ins that we shifted this around with every cohort. Actually, we originally tried with emails and that wasn't quite as effective. Then I was trying to do phone calls and that was sometimes not very effective and other times quite impactful. And then this last cohort, we really settled on the text messaging and creating a group text message. And that was highly effective. And also the cohort kind of knew each other. So it's just been learning opportunities throughout. We do provide a stipend, like what Dr. Torval was discussing, and we have free continuing education available for those modules. And we kind of bring everybody together to do this motivational interviewing workshop where people can practice different skills. This is the map of service areas. So the ones that are in the lighter yellow are the kind of the target recruitment areas. And everywhere you see an orange star is a county that we've had folks who have participated in the program from. So we're still trying to get Scott and Campbell and Breakthrough if we know people there. So if anyone on the call does, I'm happy to take contact and try to reach out. We were intentional with developing these topics and modules. I could talk about this for a very long time. Do not fret, Dr. Meshke, I will not. But we tried to link every single one of the modules back to a specific obstacle. So much in what Dr. Gammon was saying that coincides with the Farm OUD, which wasn't in existence when we designed it. Boy, that would have made this a lot easier. We kind of just took together information from our practice experience and what the research said and understood like these are maybe some deficiencies that folks are running into and that we can help them with. And so for various degrees of feedback that people have enjoyed some of these things like approaches to red flag resolution, the motivational interviewing techniques, recognizing their own stigma. And we do this in like a very approachable and easy way with examples and had borrowed some of previous training from other projects Dr. Meshke had worked with. I'll leave us here with a big piece is, well, one, DEA ordering policies and kind of dispelling some of those myths. And then understanding clientele perceptions of pharmacies and privacy considerations. I think that a really impactful piece I don't think I know, this is the feedback, a very impactful piece with everyone is understanding the lived experiences of patients and some of the situations they've been put in because of some community pharmacy interactions, which is very sad to see. There's also stories of success, but we need to be aware of how we're making people feel. Motivational interviewing workshop was via Zoom. It worked out very well via Zoom. 4 modules that kind of dug in deeper into the healing brain and how we have to change communication styles for patients. And then also practicing some motivational interviewing skills. This offered live continuing education, and there was direct mentorship provided in the workshop and having some interactions with peers as well. I'm sorry if I look down, I'm trying to keep up with time. So 4 modules overall. Module 1 was kind of the introduction. Two was practicing reframing some of the motivational interviewing principles and stages of change. And I really wanted to address that because of what Dr. Gimmon was saying, where people could work through communicating with red flags and making it more of a yellow flag situation. Sometimes the circumstances people can get into make folks, just to avoid the situation, just say, no, I'm not going to carry that, or nope, I'm not going to deal with that. And they miss an opportunity to be very impactful for chronic disease state management. So this was something very important, and that people responded well to. And then we did real life case studies based off of what some of us had experienced in practice and how we resolved issues. So the whole thing was a very great experience from our mentor standpoint, and then also feedback from the mentees. And you'll see that when we talk through these successes here. We had quite a few surveys that were built in throughout these modules. What we found was the three biggest areas where people improved was overall knowledge of MOUD, ability to care for patients with OUD, and then confidence and conflict resolution. Confidence and conflict resolution was statistically significant. I know we have a small population size though. The other two categories are still improvement, but there may have been some odd data points that we have to further assess overall. When we look at the qualitative data, and some of this that was just from open-ended questions through those quality improvement pieces and talking to folks, but these are things that people have reported in their own words. We had three key themes. So there were concepts that were likely to be applied in practice. There were things that the participants valued, which was very enlightening for me to see, and then suggestions for improvement. I wish I had a better way to make this more engaging with all the different quotes. But I listed them here. You can refer back to them if you want to, just to read it and kind of absorb in the weight of what the person is saying. But some big key things was that better understanding of patient perspective when filling MOUD. That was a great success. Understanding that communication skills needed to change, and that a lot of people had the communication skills. They practiced motivational interviewing. They just didn't often know. Well, I shouldn't say they didn't often know, but sometimes they didn't know what the terminology was and kind of what that was coming from and how they could dial it up a little bit. So that was helpful with recognizing bias. And then a very impactful one to leave on this slide was basically understanding that naloxone, is important, and that it's not often available to folks' community pharmacy if they don't have insurance or they can't afford it, essentially. So this was a training and giving them a good option to refer people onwards to a different source so they could get naloxone. So there was a conversation around being vigilant with resolving red flags. And so this is the theme. Well, I guess more of the conversation was around taking time of discussing things with people. One of the case scenarios we had is like an early refill, like what Dr. Gimmon had said. And instead of saying no, it's important to talk to folks. And in this example, real life scenario, someone, the therapy wasn't effective, so they really needed to have a dose change. And it was like an honest and pure interaction that where other people may have just sidestepped it, and it really could have set someone back. Advocating for drug take back events are important. So this is like the prescription drug misuse side of things, where over 50% of folks who misuse prescription drugs say that it first started, with using someone else's medications. And so the idea is if we can dispose properly of controlled substances, we get that out of the kind of out of the pipeline, and people will have less likely to, oh boy, how do I say it? Less likely to have initiated that with exposure from someone else's medications. So motivational interviewing strategies that people were not utilizing. One thing was rolling with resistance that people said in the workshop that really did a lot of aha moments for folks. And then just red flag resolution. So there was quite a few things for application to practice. There was a very satisfying amount, for what people valued or what our participants valued. And so folks kept saying that this was relevant to their practice. And I think that's really important when you're trying to engage a stakeholder in training who is practicing. You can't give them like figmentary or theoretical things for them to think through that don't have real world application. So they did respond well to those cases, and they thought that it was relevant to their practice, which was satisfying to hear. We tried to work hard on making sure that the modules were of an appropriate length. So it was anywhere between 12 and 18 minutes was the sweet spot, and it seemed to work. So I had feedback that was perfect length and it was easy for folks to engage with, and that they could continue on at their own pace, which was important. Because there are busy healthcare professionals. Sometimes they have more time in a day and other times they don't. Like we're in the start of the year, which is really busy right now for community pharmacies, and this is something somebody could engage with on their own time, if we can get them recruited for it. So it's very educational, easy to understand, and then also integrating into weekly workflow, which I would have loved to have gathered more information on what that was being viewed as. And just kind of wrapping things up with this, the last cohort we had was a group of pharmacists that were between several different pharmacies that were all owned by the same person. So they were familiar with each other in one way or the other, but it was like a team building exercise when we got them in the workshop. And it was a lot of fun, from my perspective, and they seemed to have a good time talking about the different experiences they have in practice and actually having had the time and space to do so. So I was able to do the training with people that I know, and I'm just picking out some of the quotes. There's way more. This is really hitting in again with the relevance for the modules and just having it easily, readily digestible, and having people being able to step out into the Zoom portion where they could talk to other people. It was very affirming, to one participant, and it was said kind of in other ways with other participants. So suggestions for improvement, they really kind of honed in on the Zoom piece. So Zoom was a really good equalizer for us to be able to get people together. Dr. Meshke and some of y'all remember it was difficult for us to figure out the best way to get people involved. There was some trial and error with a hybrid model, and in person it didn't work. Zoom is what worked out the best, and people were very engaging. There was one suggestion here that the Zoom breakout sessions didn't work, and I really appreciate seeing this because from my perspective, they didn't work either. It was better when we kept each other in a group, and you do have to be intentional. If you are wanting to do this in your own organizations or do something similar, you have to be intentional with making it more discussion based. We kind of rein in on the surveys before and after each module. So we do an onboarding and exit survey, and we're starting to do exit interviews with people. And then more case scenarios is what folks really responded well to. So then the last thing here is there was this repeated discussion of, they knew that Zoom was helpful for them, and that there may be an opportunity to get folks more involved multiple times throughout that module content by having them meet via Zoom. And, it may be a good thing for us to consider doing, mentorship sessions kind of maybe live via Zoom in scenarios like that. So we went through a couple of different things. It was very good information for us to hear as we close out the last recruitment steps for the next cohort. We can really push forward. What do we do afterwards? That's a next step, and something that I'm really interested, and if anybody has suggestions, this is great. But what we're really wanting to do is close things out and just have this recognition that we're enhancing patient care and we're trying to access or increase access to MOUD in the naloxone. And we need to do that by making sure pharmacists are compassionate and they have informed care. Reducing stigma is a really big component of this and a major barrier for patients to seek treatment. We've got to improve management and dispensing of MOUD, like what Dr. Gammon was talking about from pharmacy world perspective, reducing patient overdose through naloxone distribution, and enhancing recovery outcomes as well. So my pie in the sky kind of ideas is the standardization and consistency. I would not be a pharmacist if I didn't get a little bit of type A in here with that. So the action verbs in my mind was create, facilitate, and partner. So creating a consistent framework for addressing stigma and providing MOUD in community pharmacies. We have we have something very special here, not only with the Courage pharmacist side of things, but also with what Dr. Torval was speaking about from their perspective with other providers, and the other groups that account for the rest of the Courage project. So really taking that and keep pushing on to reduce stigma, facilitating sharing of best practices and resources, and enhancing program reach. I got to tell you, I was very surprised when we did the workshop and people were not shy with sharing their experiences. They were not shy with sharing their opinions. It was great. And I think that it really highlighted a need for pharmacists to have like um, a vocal situation where they could provide their own opinions. And I don't know of many things where you can do that within our profession. And that may be a key thing here. We would need to look into that more. And then, ultimately really partnering with the state association for a standardized approach and getting in partners to make sure that we're approaching this correctly from community pharmacy perspective. So, open it back to y'all if there's any questions or things I can elaborate on. That was a very condensed version of of everything we do in that mentoring program.
Fantastic work. Thank you so much, Tyler, for presenting all that you've done to date. It's really wonderful to see this all pulled together in such a lovely package. I would like to take this opportunity then to open up the floor to see if there are questions or comments about the material that was presented today. And if you have any suggestions or experiences that may help us build on the experiences that were shared today.
Hey, Tyler, this is Wes. I actually do have a question for you. As our students become peers and colleagues, I was wondering if there would ever be a chance to try to maybe work with the state association to develop like a peer mentoring program. Because the problem is, we're one school, we have a cohort of students, but they can sort of be like the ripple effect as they go into practice. They train more people. They have, coworkers that they work with that probably need this information. I get a lot of complaints from prescribers. Oh, this pharmacist told me this, and I get a lot of drama. And I would love, I try to do phone calls, I meet with people, but I would love if there was like a phone a friend, call a mentor. Hey, it sounds like this pharmacist and this could use a little bit more information, either whether it be about empathy or just the medication alone. It's almost like it's yeah, I'm thinking about like the professional like recovery associations. They have like a mentor program. But I wonder if we could ever work with the association, do something like that.
I love what you're saying. It's what we were thinking of when we did the Grand Challenge grants and proposing the folks that went through this training serving as the mentor, the next generation of mentors, because you really want it to be from people that are modeling the behavior. So there's a lot of room for that, Wes. And if you have good ideas or ways for us to get plugged in, I'd be happy to discuss that more. And we have talked with Anthony Pudlow, and he's aware of this, and
Yeah.
hopefully something will happen in the future. I don't want to lose momentum with it.
Okay. Yeah. Shoot me an email. I might have a couple ideas.
Okay, thank you. I don't know, Dr. Meshke, if you had anything you wanted to add to that wonderful vision or not.
No, but there is another HRSA call that's out right now, and it's for 1 year of funding. And I was thinking that this might be the possibility to at least ramp up and to enhance the program as we had discussed, if not begin to pilot it, because since it is only for a year, but at least it would give us a stronger foundation on which to build for the dissemination piece. Excellent. I have a question for our pharmacists online. I really appreciate this idea that the access to methadone may actually be increasing sometime in the future. But in thinking through methadone versus buprenorphine, and that prescribers are in certain positions where they can prescribe one or the other, in very rare cases that they can prescribe either one of them. What is the decision making around this? Does tolerance level have anything to do with whether one would recommend trying methadone or buprenorphine first? Or what is the decision making process in that? Maybe Jennifer too, with your prescribing information, could speak to that.
Well, and I don't prescribe methadone or buprenorphine, but just in all of the many conversations with Stephen Lloyd, his thing is if you're injecting 2 milligrams of heroin a day, grams, um, buprenorphine just might not be strong enough. And if it's not strong enough, what they do is they supplement with other drugs. So they might be on buprenorphine, still have cravings for heroin because, like we just learned, it doesn't light those opioid receptors up enough. So it's really the level of care they're using, from my understanding, and the amount of drugs they're using per day. And once that gets to a certain point, methadone is just going to have a higher mortality benefit for them than buprenorphine would. And then I've also heard the argument of some people need such a high level of care, with the methadone, they're required to come there every day, right? The buprenorphine they can take and go home. And then there's the opportunity that compliance could drop off. But when they're in the clinic and then they are there, they are interacting more with treatment. They're in front of the counselors more. They're in front of the peer recovery specialists more. It's just a higher compliance rate for some. That's my understanding. Again, I don't prescribe it.
Yeah, and Dr. Meshi, I'm glad you extended this by another hour so we could dive into this further. Because there's a lot of patient-specific situations. Like I said, what have they used in the past? How much have they been using? Have they responded to one? Have they tried one before? All other things considered, the best treatment is the one that patients can get. So talking about those access issues, you have someone in the Upper Cumberland, methadone is not an option because they can't access it. Some person may be a really great option for the long-acting injectable buprenorphine, but it's also very expensive, so they can't access it. So the best treatment is the one that the patient agrees to that they have access to. There may be some scenarios and other specific situations that may lean you to one or the other. But we just need to make sure that everything is as available as we can make it. With the methadone in pharmacies, it's very interesting that the one organization that was very strongly opposed to that was the association that supports methadone clinics. The way it was proposed, you would still have to be a provider at a methadone clinic, but instead of dispensing it yourself, you have the ability to write a prescription. I think we still have a lot more work to do about stigma. If we're already having a hard time getting pharmacist access to buprenorphine, what's the likelihood of the adoption of dispensing methadone for addiction? So there's those arguments as well. Um, from a patient perspective, it would be great. The clinics are great. You have lots of access to your care team. But depending on how busy they are, and we don't have very many of them, the waits are very long. It would be great if I only had to go to the clinic to just see my counselor, see my provider, but yet I'm having to go like every day or maybe a few times each week. And literally all I'm doing is going and getting my medicine. And I sure as heck got a really nice Walgreens down the street. And I don't have to drive an hour in traffic and stand in line when all I need is my medicine. So I think it's probably going to take part of people a lot smarter than me to determine the right way to go there. Um, as a state, we do have a lot of lawmakers who are very cautious about medications for opioid use disorder. In my talk, we talked about all of these restrictions on buprenorphine. Um, so there's no telling what they would do when methadone's been more available. It's something you have to consider as well. So there's just, there's a whole nother hour of discussion packed in that question.
Thank you so very much. We do have a couple minutes left. I did put up the evaluation again. The QR code can be accessed via your phone to respond with your opinions about how our learning objectives were achieved or not, and your reactions to the presenters, and any presentation you would like to see in the future. So we are always looking for new ideas, and then our next spring meeting, we will be looking at harm reduction services. So we have good things upcoming, and we always want to keep up to date on the topics that you believe would be important to address as well. So I am not seeing anything further in the chat. So presenters, anything further before we wrap up for the day?
Well, thanks for the invite.
Yep, thanks for the invite and pleasure to hear the other presenters. Definitely learned a few things, so all wonderful information.
Yes, thank you very much. As a presenter and a participant, I very much enjoyed it.
It was an excellent session. So we will have the recording up next week. And I would ask the presenters, if you haven't already, to send me your slides and we'll put those up as well. And I just want to again extend my greatest gratitude to Drs. Torville, Melton, and Gemin for the information they shared and the expertise that they bring to our state. So without further ado, have a lovely weekend. Thank you.